This recorded lecture will be going over Chapter 10, Drugs for Central Nervous System Problems, in the Evolved Introduction to Clinical Pharmacology textbook. The brain monitors and regulates the coordination of body system and activities, including movement, endocrine secretions, and intellectual functions like thinking and decision making. The nerve endings of specialized photoreceptor cells, the rods and cones in the retina, can detect and convert light into signals that are then sent through the optic nerve into the brain. Many problems that occur inside or outside of the CNS can affect brain function. Movement is an important motor function that involves the brain, spinal cord, nerves, muscles, and bones. Transmission of electrical impulses between neurons depends on the release of neurotransmitters. A neurotransmitter is a chemical that is released from the end of one nerve, crosses a synaptic cleft, and then binds to receptors on the next nerve in the line. Neurotransmitters can be excitatory or inhibitory. Excitatory or excitatory neurotransmitters include acetylcholine, epinephrine, and norepinephrine. Inhibitory neurotransmitters include dopamine, some types of serotonin, and gamma aminobutyric acid, or GABA. Smooth movement requires input from an excitatory neurotransmitter, typically acetylcholine, and an inhibitory neurotransmitter, usually dopamine. Without dopamine to modify arm and muscle contractions, your arm movement would be fast, jerky, and wild. Some problems that occur in the CNS, like Parkinson's disease, result from an imbalance of excitatory and inhibitory neurotransmitters. Diagnosis for Parkinson's disease can be made after all other neurologic disease processes have been ruled out. The disease manifests as movement disorders and is associated with the presence of Lewy bodies in the brain. PD is a CNS disorder in which not enough dopamine is available to modify excitatory signals to skeletal muscles. Movements become hard to control and jerky, and some muscles are rigid because they fail to relax sufficiently. The neurologic problems also cause facial features to become mask-like. The risk of falls will greatly increase. Depression, hallucinations, anxiety, and delusions are frequent complications of PD. The PD drugs increase the dopamine levels to improve the motor symptoms, but unfortunately, increasing dopamine supply can also lead to hallucinations and delusions. Although drug therapy does not cure PD, it can delay worsening of symptoms and allow patients to remain independent longer. Drug therapy for PD includes dopamine and dopamine agonists, catechol O-methyltransferase or COMT inhibitors, and monoamine oxidase type B or MAO-B inhibitors. Anticholinergic drugs are no longer the most common therapy for PD. A dopamine agonist is a drug that has the same chemical structure as natural dopamine and is used to increase the levels of dopamine in the brain to restore balance between the actions of acetylcholine and dopamine. The therapeutic effect of these drugs helps reduce muscle tremors and rigidity and improves mobility, muscular coordination, and performance. National Parkinson Foundation recommends that carbidopa-levodopa should be used as a first-line treatment for patients with PD who are older than 70 years of age, and that the newer dopamine agonists like pramipexole, ropinirole, and rotigotine be used as a first-line treatment in patients between the ages of 50 and 70 years. All patients will eventually require levodopa because dopamine becomes deficient in PD. Carbidopa is typically given in combination with levodopa because it allows more levodopa to get into brain cells. This means that a lower dose of levodopa can be used, preventing nausea and vomiting that typically accompanies the increasing levodopa doses needed to control disease symptoms. Levodopa is rarely given alone for this reason. Wearing off is an issue of a drug losing its effectiveness. This can occur after levodopa has been used for several years. The action of levodopa peaks in about 1 hour after administration, and it wears off in 4 to 5 hours. The wearing off effect causes rapid swings of symptoms. The extended release form of carbidopa levodopa and the longer half-lives of dopamine agonists will help to prevent this effect. The most common side effects of carbidopa levodopa and all dopamine agonists include postural and general hypotension, headache, GI disturbances, insomnia, dream abnormalities, decreased impulse control, and confusion. The most common adverse reaction to carbidopa levodopa is dyskinesia. This results in involuntary muscle movements that look like uncoordinated dance movements. Dopamine agonists can also cause delirium, psychosis, and hallucinations. If any of these problems occur, the healthcare provider will need to determine whether the symptoms are related to the advancing disease process, depression, or the PD drug. The nurse should hold the next dose and notify the doctor. Carbidopa levodopa dosages may need to be decreased as COMT inhibitors and MALB inhibitors are added to the drug regimen. This can precipitate neuroleptic malignant syndrome with symptoms of agitation, coma, muscle rigidity, tremors, high fever, and an unstable blood pressure. These drugs are best absorbed on an empty stomach. Use of antihypertensive agents with dopamine agonists can lead to severe hypotension. Phenytoin reduces the effectiveness of dopamine agonists. Use of dopamine agonists with sedatives will worsen drowsiness and increase the risk of confusion, hallucinations, and delusions, especially in patients already suffering from mental illness. Dopamine agonists frequently cause postural hypotension, and you should take a full set of vital signs, including orthostatic blood pressure readings. Ask whether the patients have had melanoma or closed-angle glaucoma, because these conditions are contraindicated for dopamine agonist therapy because the drugs can worsen them. Levodopa can cause hypoglycemia. You should monitor liver enzymes before and at intervals during treatment because other drugs used in the treatment of PD are metabolized by the liver. Dopamine agonists are recommended to be given 30 to 60 minutes before meals for better absorption and for maximum effect so that the patient has less difficulty chewing and swallowing, which lessens the risk of aspiration. Dopamine agonists should be withdrawn slowly because these drugs have a long half-life. Sustained release capsules are not recommended for initial therapy because they do not allow enough flexibility in dosage regulation. Long-term use of dopamine agonists may lead to akinesia. This is a loss of movement. Tardive dyskinesia, which is abnormal and involuntary movements, especially of the lower face, and dystonia. This is impairment of muscle tone. Report any abnormal involuntary movements like chewing, grinding of the teeth, protrusion of the tongue, repeated opening and closing of the mouth, head bobbing, or jerky, constant movements of the feet or hands, because these all can indicate dystonia. This could be related to progression of the disease itself or the wearing off of dopamine. Teach your patient and family the following. Clinical improvements are cumulative, and it may take 2 to 3 weeks to reach a full effect. If possible, take the drug on an empty stomach 30 to 60 minutes before meals or snacks. If the drug causes nausea, you can take it with some crackers or another carbohydrate. Avoid taking levodopa with vitamin B6 because the vitamin accelerates inactivation of the drug. Contact your healthcare provider if symptoms suddenly become worse, or if you have intermittent winking or muscle twitching, or if abdominal pain, constipation, distension, or urinary problems occur. Take care when using drugs for sleep, for pain, to relax muscles, or to control bladder function, along with your drugs for PD, because this combination can lead to confusion, hallucinations, and other symptoms. Change position slowly, and contact your healthcare provider as soon as possible if you develop any hallucinations or delusions. A catechol-O-methyltransferase or COMT inhibitor is a drug that suppresses the activity of the COMT enzyme so that naturally occurring dopamine and dopamine agonists remain active in the body longer, helping to restore the acetylcholine dopamine balance in the brain. A COMT inhibitor will be given with levodopa to allow blood levels of levodopa to stay high enough to enter the brain, where it is then converted to dopamine. Entacapone and tolcapone are COMT inhibitors that are used for PD. The most common expected side effects are GI upset and discoloration of the urine. Tolcapone is not used in persons with existing hepatic disease, and liver function must be closely monitored every 6 months if tolcapone is used. Neither entacapone nor tolcapone should be taken with other MAO inhibitors, especially phenelzine, because they will reduce catecholamine metabolism and cause cardiovascular problems like severe hypertension, tachycardia, and dysrhythmias. The patient may experience orthostatic hypotension because COMT inhibitors potentiate the action of carbidopa levodopa. Monitor your patients for depression and psychosis. Teach your patient and family the following. Take entacapone with each levodopa carbidopa dose for the best effect. The first dose of tolcapone will be given with levodopa carbidopa, and subsequent doses will be given 6 to 12 hours later. Notify your healthcare provider if you develop jaundice, abdominal pain, or swelling, because all of these symptoms can indicate liver failure. Notify your healthcare provider if you have worsening depression, delirium, or hallucinations. Do not suddenly stop taking either of these drugs. Your urine may have a brownish orange color discoloration. This is an expected side effect and it is not dangerous. Rise slowly from a sitting or lying position. MAO type A breaks down many neurotransmitters, including epinephrine, norepinephrine, serotonin, and dopamine. A monoamine oxidase type B or MAO-B inhibitor will suppress the action of MAO-B, which allows dopamine levels to increase and reduces the symptoms of PD. MAO-B inhibitors are sometimes used to treat depression because this drug category also reduces the breakdown of serotonin. 3 MAO-B inhibitor drugs, selegiline, rasogiline, and safinamide, are used in combination with carbidopa levodopa. Adding MAO-B inhibitors to the drug regimen will allow the dose of levodopa to be decreased. This lessens the side effects of higher levodopa levels. The usual side effects of MAO-B inhibitors are dry mouth, nausea, constipation, and lightheadedness. Confusion and hallucinations occur. The adverse effect of severe hypertension can occur if MAO-B inhibitors are used in high doses, but this is unlikely to occur at lower doses. Tyramine-rich foods should be avoided when taking any MAO inhibitor because they can cause a severe hypertensive crisis. These drugs cause drowsiness. MAO-B inhibitors interact with some opiate drugs used for pain, like meperidine, tramadol, and methadone, and they can lead to a hypertensive crisis. Drugs that stimulate the sympathetic nervous system, like amphetamines, phenylephrine, and dextromorphan, can cause a hypertensive crisis. Monitor all patients closely for behavior changes because some of these drugs could cause hallucinations, delusions, depression, or confusion. Teach your patient and family the following. These drugs can take several weeks to begin to work. Do not exceed the prescribed drug dose because doing so can raise high blood pressure levels to a dangerous level. Avoid foods that contain tyramine, like beer, red wine, aged cheese, smoked meat, cheese, fish, soy products, and pickled herring. Report symptoms of very high blood pressure. Very low blood pressure, dizziness, lightheadedness, and fainting are possible. Do not take over-the-counter drugs or herbs without checking with your pharmacist or provider. These drugs can cause drowsiness, so avoid driving or using dangerous machinery until you know how the drug affects you. Wear sunscreen, sunglasses, and protective clothing when outside because this drug increases the risk of serious sunburn, even if you have dark skin. There are many causes and types of dementia, and Alzheimer's disease is one that can be helped initially with drug therapy. Levels of the excitatory neurotransmitter acetylcholine are decreased in the brain. This results in more difficulty with memory and learning. The diagnosis is made based on symptoms, family interviews, physical examination, and neurologic and cognitive examinations. Drug therapy will not cure AD. Drugs used for AD, which provide only temporary improvement in the symptoms, include cholinesterase inhibitors and N-methyl D aspartate or NMDA blockers. Drug therapy attempts to increase the acetylcholine levels because this excitatory neurotransmitter is reduced in the brains of patients with AD. A cholinesterase inhibitor is a drug that binds to acetylcholinesterase and slows its action, which allows any acetylcholine produced to remain functional longer. This action appears to delay memory loss and improves the patient's ability to perform their activities of daily living. Unfortunately, this drug is useful only temporarily. As the disease progresses, fewer intact neurons are available to make acetylcholine, and when this occurs, the drug is no longer effective. 3 cholinesterase inhibitors are used in the treatment of AD: donepezil, rivastigmine, and galantamine. Expected side effects of cholinesterase inhibitors include mild diarrhea, especially when starting the treatment, drowsiness, headache, loss of appetite, GI discomfort, joint pain, and muscle cramping can occur. Adverse effects include hallucinations, dysrhythmias, GI bleeding, infection, and difficulty urinating or incontinence. Cholinesterase inhibitors should not be given with other drugs that could prolong the QT interval on an EKG, because this fatal dysrhythmia, known as Torsades de Pointes, a form of VTAC, can occur. Dextromorphan, quinidine, and fluconazole are 3 of these types of drugs. Obtain a baseline weight measurement and reassess it at a weekly interval because these drugs can cause a loss of appetite. Before a patient starts a cholinesterase inhibitor, assess the patient using an Alzheimer's disease assessment scale so that an objective evaluation can be made when evaluating for symptom improvement. Monitor patients who have asthma carefully for worsening of symptoms. Teach your patient and family the following. It can take several weeks for drugs to have a therapeutic effect. These drugs do not cure AD. And if difficulty breathing, fainting, or GI bleeding occur, notify your healthcare provider immediately. Notify your healthcare provider if the expected side effects are causing increased discomfort or if any new symptoms develop. Use the bathroom every 2 hours to avoid urinary incontinence. Take donepezil at bedtime. Take galantamine and rivastigmine at the same time, twice daily with food to avoid GI upset. The risk of falls is increased, and keep all follow-up appointments. N-methyl D aspartate or NMDA blockers are drugs that prevent the entrance of calcium into neurons. This reduces or slows the neuronal damage in AD. Mementine is used with the drugs donepezil, rivastigmine, and galantamine to increase the effects of these cholinergic agonists. The expected side effects of memantine include headaches, dizziness, and constipation. Adverse side effects include hallucinations, worsening confusion, depression, somnolence, shortness of breath, incontinence, and weight loss. Drugs that increase the urine pH or are excreted by the kidneys can all interfere with the renal excretion of memantine, and they can increase the expected and adverse side effects. Memantine is eliminated primarily by the kidney, and it should be used with caution in patients with kidney disease, those at risk for renal impairment due to their age, and people taking other drugs that also have a risk of renal impairment. If the patient has symptoms of a UTI, obtain a urinalysis and consult with the healthcare provider before starting drug therapy. Teach your patient and family the following. Take or give memantine at the same time every day. The extended release capsule can be opened and all of the contents can be sprinkled on applesauce. If using the liquid form of the drug, do not mix it with any other liquids. Report problems with vision, rash, shortness of breath, agitation or restlessness, confusion, dizziness, incontinence, and weight loss to your healthcare provider. Avoid driving or engaging in hazardous activities until you know how this drug affects you. Report any symptoms of a UTI to your healthcare provider. A convulsion is the part of a seizure that is seen as the motor response to brain signals. Symptoms of seizures will vary with the area of the brain affected and the type of seizure experienced. Seizures are classified as partial or generalized. Epilepsy is one cause of chronic and recurring seizures. An anti-epileptic drug, or an AED, is a drug that reduces or prevents seizures. Traditional AEDs include phenytoin, carbamazepine, ethosuximide, phenobarbital, and valproic acid. Although these older drugs have more side effects and issues than do some of our newer AEDs, they are still used effectively today for most patients, and sometimes in combination with our newer AEDs. Phenytoin is an AED that reduces or prevents seizures by binding to sodium channels on nerve membranes and making them less active. This prevents the spread of neuron excitation. Phenytoin anticonvulsants are approved only for the treatment of seizure disorders. Carbamazepine is an AED that limits the spread of neuron excitation by altering the sodium channels of nerve membranes to prevent or slow the refiring of neurons. This drug is often used to control epilepsy in children. It is also used as a mood stabilizer and to reduce skeletal muscle spasms. Ethosuximide is an AED that raises the seizure threshold by altering calcium channels on the neuron membranes. Although this drug can help reduce all types of seizures, it is most effective for absent seizures. Phenobarbital is a drug from the barbiturate class that raises the seizure threshold by enhancing the action of the inhibitory neurotransmitter GABA. This results in widespread CNS depression. It is the oldest drug used to control seizures, and it is also used as a sedating agent. Primidone is a prodrug that is converted to phenobarbital in the body. It has the same actions, side effects, interactions, and precautions as phenobarbital. Valproic acid is an AED that raises the seizure threshold by possibly increasing the activity of inhibitory neurotransmitter GABA. Valproic acid is used to help manage different types of bipolar disorders. The most common side effect of phenytoin is gum hyperplasia, especially with long-term use. Other common side effects include abdominal discomfort. The most common side effects of carbamazepine include constipation, nausea, vomiting, and ataxia. Ethosuximide has fewer side effects than the other traditional AEDs. The most common side effect of this drug are heartburn, nausea, vomiting, dizziness, drowsiness, and fatigue. Adverse effects of this drug are rare. Phenobarbital and primidone have many CNS side effects, especially drowsiness and ataxia. These problems are most apparent when therapy first begins, and they do become less severe over time. The most common side effects of valproic acid are drowsiness, muscle weakness, nausea, diarrhea, and menstrual irregularities. Phenytoin is a known tetragen that causes birth defects. Other adverse effects of phenytoin include the red blood cell problem of anemia, reduced white blood cell counts with an increased risk of infection, and reduced platelet counts with an increased risk of bleeding. Bradycardia can occur. Rashes caused by phenytoin can progress to a widespread and serious problem known as Stevens-Johnson syndrome. This can result in skin slowing and other complications that require immediate attention. Carbamazepine, like phenytoin, affects the bone marrow. Phenobarbital and primidone can cause severe CNS depression, especially when given parenterally. They can also cause respiratory depression. Phenobarbital has an increased risk of physical and psychological dependency, especially with long-term use, and it is classified as a Schedule IV controlled substance. Valproic acid has been known to cause amnesia and heart rhythm irregularities, especially tachycardia. Hearing loss and GI bleeding are also possible. The list of drugs that interact with all of the traditional AEDs is very long and includes very common drugs like aspirin, acetaminophen, oral contraceptives, proton pump inhibitors, and drugs for diabetes. To prevent severe complications and adverse reactions, avoid other prescription drugs unless the benefit outweighs the interaction risks. Most of our newer anti-epileptic drugs will be used along with or added to a regimen that includes traditional AEDs. This type of add-on therapy is known as adjuvant therapy. On page 182 in the orange memory jogger box, you can see the 4 newer AEDs that are approved for use as monotherapy. Oxcarbazepine raises the seizure threshold, and it is approved for use to control partial seizures. The most common side effects of oxcarbazepine include drowsiness, dizziness, headache, and nausea. Visual side effects of double vision and blurred vision can also occur. The most common adverse effects are amnesia and low sodium levels. Oxcarbazepine lowers blood sodium levels. This effect can be intensified when the patient is also taking sodium excreting diuretics. Oxcarbazepine interacts with many drugs. Patients should avoid other prescription drugs unless the benefit outweighs interaction risks. If these visual changes are present, you should instruct the patient not to drive or operate dangerous machinery to avoid accident or injury. Assess for any symptoms associated with low sodium levels, including headache, increased muscle weakness, and decreased deep tendon reflexes. In addition to the teaching points listed in box 10.7 on page 183, teach your patient and family who is taking oxcarbazepine and their family the following. Keep all appointments for lab testing, because this drug can cause electrolyte problems and decrease blood counts. Do not drive or operate dangerous equipment if you are experiencing blurred or double vision. If you notice increased muscle weakness and a persistent headache, notify your healthcare provider immediately. If you are taking an oral contraceptive, use an additional form of contraception to prevent an unplanned pregnancy, because this drug will reduce the effectiveness of hormonal contraceptives. Lamotrigine is a newer AED. It is approved for use as monotherapy for partial seizures, tonic-clonic seizures, and seizures associated with Lennox-Gastaut syndrome. It is approved for some types of bipolar disorders. The most common side effects of lamotrigine are drowsiness, abdominal pain, and visual disturbances. Other side effects include ataxia, dry mouth, and dizziness. Lamotrigine can cause life-threatening rashes, including Stevens-Johnson syndrome and toxic epidermal necrolysis. It has a black box warning that instructs immediate discontinuation of a drug if a rash appears during treatment. Lamotrigine interacts with many drugs, especially aspirin, acetaminophen, oral contraceptives, proton pump inhibitors, cardiac drugs, drugs for psychiatric problems, drugs for HIV disease, drugs for tuberculosis, and drugs for diabetes. Assess the patient daily for a rash, which can signal the beginning of life-threatening skin reactions. If a rash is present, withhold the dose and notify the healthcare provider immediately. In addition to the teaching points listed in box 10.7, teach your patient who is taking lamotrigine and their family the following. Check yourself every day for rashes. If you are taking the extended release form of the drug, swallow it whole and do not crush or open it. If your mouth becomes uncomfortably dry, you can chew gum, suck hard candy, and drink more water to help that problem. Do not drive or operate dangerous equipment if your vision is blurred or double. Lacosamide is approved for use as a monotherapy agent to control partial seizures and can be used as an adjuvant therapy with some other AEDs. The most common side effects of lacosamide include headache, dizziness, blurred vision, and double vision. Other side effects include fatigue, nausea, and ataxia. Many people who are taking lacosamide experience euphoria, a feeling of intense well-being and happiness. This is considered an adverse reaction because it can lead to psychological dependence, but not addiction. Orthostatic hypotension and an increased risk of falls and injury can also occur. Lacosamide interacts with many drugs, especially cardiac drugs, antihypertensive drugs, drugs for psychiatric problems, drugs for HIV disease, antifungal drugs, and drugs for tuberculosis. Assess your patient's blood pressure before and after giving this drug because it can cause severe hypotension. If these visual changes are present or the drug makes the patient dizzy, instruct him or her not to drive or operate dangerous machinery to avoid any accident or injury. When giving this drug intravenously, infuse it slowly over 30 to 60 minutes. Observe the patient for mood changes after taking this drug. In addition to the teaching points listed in box 10.7, teach your patient and family the following. Change position slowly. Report any unexpected loss of consciousness to your healthcare provider. Do not drive or operate dangerous machinery if your vision is affected. Some people will feel especially happy or even high when they take this drug, and they may be tempted to take it more often. Regardless of this mood change, do not take the drug more often than prescribed. Topiramate acts on the sodium channels to stabilize neuron membranes and prevent repetitive excitation and firing. It enhances the inhibitory neurotransmitter GABA, and it blocks some excitatory receptors. It is approved for use as monotherapy for partial seizures, tonic-clonic seizures, and seizures associated with Lennox-Gastaut syndrome. Common side effects of topiramate include abdominal pain, nausea, dizziness, drowsiness, and fatigue. Additional side effects include taste changes, anorexia, and paresthesias. Adverse reactions include memory impairment and electrolyte imbalances, metabolic problems, as well as elevated ammonia levels. Symptoms of elevated ammonia levels and encephalopathy include unexplained lethargy, vomiting, changes in mental status, and a low core body temperature. Topiramate is a known tetragen that causes birth defects. Topiramate interacts with many drugs, especially aspirin, acetaminophen, oral contraceptives, cardiac drugs, diuretics, antihypertensives, antifungals, drugs for psychiatric problems, drugs for HIV disease, drugs for tuberculosis, drugs that affect blood clotting, and drugs for diabetes. Be prepared to draw blood for the measurement of the ammonia level. A normal ammonia level is 10 to 80 micrograms per deciliter. Monitor lab values, especially pH and electrolytes, because this drug will increase the risk of metabolic acidosis. In addition to the teaching points listed in box 10.7, teach your patient and family the following. If you suddenly become lethargic and confused, or have vomiting, or if your temperature falls below 95 degrees Fahrenheit, call your healthcare provider immediately. Do not chew or crush the capsules. Do not chew or break the tablet form of the drug. MS has a variety of types, the most common being relapsing remitting MS, or RRMS. MS cannot be cured, but drug therapy can slow the progression and allow patients to remain functionally independent longer. Management of MS is performed by neurologic healthcare providers and specialized clinics. Initial drug therapy is started with these specialists. The drugs discussed in this chapter are primarily used for RRMS. Corticosteroids can be used occasionally at lower dosages in addition to the more specific drug therapies for MS. The three broad categories of drugs to reduce MS symptoms, slow the progression, and increase the duration of remissions are the biological response modifiers, or BRMs, monoclonal antibodies, and neurologic drugs. A biological response modifier is a drug that alters the patient's immune response to abnormal triggers of immunity and inflammation. The two injectable BRMs include beta interferon and glatiramer. The oral drugs are fingolimod and teriflunomide. Monoclonal antibodies for MS attack and inactivate or destroy lymphocytes that are involved in the direct destruction of myelin or produce chemicals, such as cytokines, that trigger the immune system to destroy myelin. All of these drugs will increase the risk of infection by reducing general immunity and can trigger severe allergic reactions. These drugs will all be given as IV infusions on a specific schedule that can range from once a month to once every 6 months or once a year. Neurologic drugs approved specifically for MS include dimethyl fumarate and dalfamipridine. Both of these are oral drugs that must be taken daily to help improve the symptoms of MS. Dimethyl fumarate reduces inflammation in the CNS. This helps protect neurons and myelin from damage. Dalfampridine blocks potassium channels in unmyelinated nerves, helping them to continue to function. ALS patients will have an excess of glutamate in their brain and spinal cord. Glutamate is an amino acid that can be toxic to nerve cells, and drug therapy will be designed to moderate and inhibit the action of glutamate. Riluzole reduces the actions of glutamate by inhibiting or blocking the action and/or release of glutamate. It helps to prolong the life of an ALS patient by 3 months. Weakness, lack of energy, diarrhea, anorexia, nausea, vomiting are the most frequently reported side effects. Hepatic enzyme elevation and hepatotoxicity can occur. Neutropenia, anemia, and kidney dysfunction are the rare adverse reactions of the drug. Riluzole should be used with caution with dextromorphan. Liver function enzymes should be monitored before and during the course of therapy every month for the first 3 months, every 3 months for the remainder of the first year, and then periodically as needed after that. Several cases of interstitial lung disease have been reported with riluzole, and you should check with the healthcare provider if the patient has pulmonary disease. Riluzole should be given at least 1 hour before or 2 hours after a meal. This drug should not be given to patients who are pregnant or breastfeeding. Differentiating adverse effects from the actions of riluzole can be difficult because the manifestations of ALS, including weakness and lack of energy, can often be associated with side effects. Teach your patient and family the following. The dose should not be increased. Report any febrile illness to the healthcare provider. Driving or engaging in potentially hazardous activities before the response to the drug is known can be dangerous, and it should not be undertaken. Do not breastfeed while taking this drug, and do not drink alcohol while taking this drug due to potential adverse effects. Acetylcholinesterase or cholinesterase is an enzyme that breaks down acetylcholine in the brain. In myasthenia gravis, acetylcholine levels are deficient. This explains the muscle weakness and fatigue that is experienced by patients with this disease. Acetylcholinesterase inhibitors, also known as cholinesterase inhibitors, are the basic treatment for myasthenia gravis. Pyridostigmine has a half-life of 3 to 4 hours and can be used for the long-term maintenance therapy for the disease. The most common side effects for the use of edrorphium and pyridostigmine are related to the cholinergic activity of the GI system. Nausea, vomiting, diarrhea, stomach cramps, abdominal pain, difficulty swallowing, and increased salivation are the most common side effects. Bradycardia and other dysrhythmias can occur. Severe adverse reactions include respiratory depression and respiratory arrest. Cardiac arrest can occur during a cholinergic crisis. Increased bronchial secretions, laryngospasm, and bronchial constriction can also occur. Other cholinesterase inhibitors can produce additive effects and increase the chance for a cholinergic crisis. Tricyclic antidepressants can antagonize some of the effects of the drugs that mimic or enhance the parasympathetic nervous system. Pyridostigmine should be used in caution in patients with bronchial asthma, COPD, bradycardia, or cardiac dysrhythmias. The doses should be spaced at least 6 hours apart. Atropine should be readily available in the event of a symptomatic bradycardia like hypotension. Evaluate and report any muscular weakness, cramps, or muscular fasciculations. Teach your patient and family the following. If you miss a dose, take it as soon as you can. If it's almost time for your next dose, then take only that dose. Do not double or take extra doses. The duration of the drug action can vary with physical and emotional stress and disease severity. Report the onset of rash to the healthcare provider. Sustained release tablets can become spotted in appearance, but this will not affect the potency of the drug. Do not breastfeed while taking this drug before consulting your healthcare provider.